Okay, so for abortion, we are having a scenario that abortion. Okay, that there is a G3P4 with 10 weeks amenorrhea and has ultrasound findings of missed abortion. So define missed abortion and enumerate the different types of abortion, investigations, and management. Another scenario is that an ultrasound of P1 with 8 weeks gestation and after slight vaginal bleeding confirms missed abortion. Differentiate between inevitable abortion and missed abortion on the basis of signs, symptoms, and examination, investigations, and management. So we are having the classification of abortion as spontaneous abortion and induced or specific abortion. In spontaneous abortion, we are having threatened abortion, inevitable abortion, incomplete abortion, complete abortion, and missed abortion. Then we are having the recurrent abortion and septic abortion. Abortion is the expulsion or extraction from its mother of a fetus before 24 completed weeks of gestation or an embryo weighing 500 gram or less. This is the definition of abortion, that it is expulsion or extraction of a fetus from its mother before 24 completed weeks of gestation or an embryo who is weighing 500 gram or less. Missed abortion is the intrauterine fetal demise before 24 weeks gestation and uterus makes no attempt to expel it. This is missed abortion. The clinical features are regression of the pregnancy symptoms, that is nausea or vomiting, urinary frequency, and breast changes, vaginal bleeding, that is brown or black color, fundal height, that is reduced height of the uterus compared to the gestation, and fetal movements, that is decreased, and pain. There is not prominent feature in missed abortion. The investigations are on examination, small amount of dark blood present on the vagina, and uterus is soft, non-tender, and decreased size than the normal. That is period of gestation. Then on ultrasound, absent fetal cardiac activity is present. On routine investigation, hepatitis B, HIV screening, CBC, urine RE, and blood sugar is done. And coagulation profile is done. That is PT, PTTT because of the risk of DNC. The management options are conservative manage to observe the spontaneous expulsion may occur. The active management is either opted as primary treatment or after the failure of conservative manage. And the first trimester abortion, the patient presents before the 12th week of gestation. Suction and curettage is the method of choice for the evacuation of uterus. The procedure is that admit the patient, counsel her for induction, keep her nil by mouth, arrangement of blood, 3 mg prostaglandin pessary in posterior fornix of the vagina 6 hours prior to evacuation, or cytotec is used for induction, which cause cervical ripening or wait next day under general anesthesia. Then second trimester abortion. If patient present after 12 weeks of gestation, expulsion of the products of the conception, induction of the labor, and advice Okay, the procedure is admit the patient, counsel her for induction, and prostaglandin is given, which is 3 mg per 6 hour, and then give oxytocin where she expel herself. If expelled, do evacuation and curettage for retained products of conception. May be due to severe bleeding, it can end in hysterectomy, so counseling of the patient is important. The complications are hypovolemia and shock, DIC, RH isoimmunization, sepsis, DVT, renal failure, chronic sequelae of anemia, and PID. Other agents like hypertonic glucose, saline, and these are when injected intraamniotically induce labor effectively, but risk of the infection, that is hypernatremia, and disseminated intravascular coagulation limits this use. Hysterectomy is done, that is C-section. So we have discussed the abortion. Then we have discussed that what is the scenario for abortion and what are the classification, that is abortion, spontaneous abortion and induced abortion. The spontaneous is then threatened abortion, inevitable abortion, incomplete abortion, complete abortion, and missed abortion. Then we have discussed the definition of the abortion, and then we discuss the missed abortion specifically, the clinical features for the missed abortion, the investigation options, which are examination, ultrasound, routine investigations, and coagulation profile. Then we discuss the management options, which are conservative management and active management. Then first trimester abortion, that is patient present before the 12 weeks of gestation and the procedure for it, and the second trimester abortion and the procedure for it, and then the complications of the abortion and what are other agents that use. Now we will discuss the next topic, that is recurrent abortion. Okay, now recurrent abortion. For recurrent abortion, we are having a scenario that define recurrent abortion and how you would manage such case. Recurrent abortion is a 3 or more consecutive spontaneous abortions, and it is primary or secondary. Primary is if patient has never had a successful pregnancy, and secondary is if patient has delivered one or more infants before the series of abortion. Now, the causes of recurrent abortion are genetic, anatomical, endocrine, immunological, systemic disorders, smoking, and alcohol consumptions. The main causes of recurrent abortion are cervical incompetence, separate uterus, and repeated bacterial vaginosis. The genetic factors are the causes, the anatomical factors are the causes, the endocrine factors are the causes, immunological factors are the causes, the systemic disorders, and the smoking and alcohol are the causes. The genetic factors are chromosomal abnormalities and multifactorial problems. The anatomical factors are congenital anomalies of the uterus, intrauterine synecdoche, fibroid uterus, and incomplete cervix. The endocrine factors are polycystic ovarian disease, corpus luteum insufficiency, diabetes mellitus, and thyroid dysfunction. The immunological factors are alloimmune factor and autoimmune disease. And then the systemic disorders and the smoking and alcohol. Now, the management options for recurrent abortions are that first of all, history of the patient is taken, that is of previous abortions. In the first trimester, chromosomal abnormalities, and in the second trimester, anatomical, endocrine, and autoimmune factors are the history of these things are taken. Then examination is done, investigation is done. On investigation, routine investigation is done, karyotyping is done, karyotyping of both the parents, the history of fetal malformation in previous pregnancy or family. Then ultrasound is done, which is for congenital malformation and fibroid and polycystic ovaries. Hysterosalpingogram is done for submucous fibroids and congenital uterine anomalies can be easily picked. And hysteroscopy is done to divert the visualizing of uterine cavity, and hormone assays is done. There is luteinizing hormone and follicle stimulating hormone, and thyroid function tests are done. Biochemistry is done for glucose tolerance test and HbA1c for diabetes mellitus. Blood tests are done, that is FBC, APTT. Serological tests are done for connective tissue disorders and lupus anticoagulants and ANA or anticardiolipin antibodies. Then we will do the treatment. For treatment, first of all, the counseling of the patient is done. That is, couple suffering from recurrent abortion is generally depressed. They need to be reassured and deal with a positive approach. Facts must be conveyed to the patient in a positive way. Studies have shown that psychotherapy improves outcome in recurrent abortions. Now we will treat the cause. For example, if it is due to uterine anomalies, then surgical correction is done. Cervical cerclage helps in the patients with unicornuate uterus, and cervical incompetence treated with cervical cerclage called McDonald sutures. Chromosomal problems are corrected, that is karyotyping of both the partners. Then endocrine disorders are corrected, that is for pituitary suppression with gonadotropin releasing agonist followed by HCG administration has been found to be useful in prevention of PCO related recurrent abortion. Injection HCG 5000 IU given a week from 5th to 14th week has been reported to prevent the abortion in small number of patients. Thyroid dysfunction treatment is done, high diabetic control is provided, immunological therapy is given, and give multivitamins and folic acids. So this is the treatment for the recurrent abortion. We have discussed the recurrent abortion, that what is the scenario. So we have defined the recurrent abortion and then how we will manage it. When there is 3 or more consecutive spontaneous abortion, it is recurrent abortion and it may be primary or secondary. Then we have discussed the causes, then the genetic factors, the anatomical factors, endocrine factors, and the immunological factors. Then we have discussed the management options. First of all, history is taken, then examination, investigations are done. Investigation, routine investigation, which are karyotyping, ultrasound, hysterosalpingogram, hysteroscopy, hormone assays, biochemistry, blood test, and serological tests are done. Then treatment is providing, which is counseling. And then the management options are done, which is first of all, the uterine anomalies is treated if it is a cause, then chromosomal problems, the endocrine disorders, the thyroid dysfunction treatment, the high diabetic control, and immunological therapy, and give multivitamin and folic acid. Now coming towards the septic abortion. Okay, now coming towards the septic abortion. For septic abortion, we are having a scenario that there is a 20 years P2 has come to GOPD with the history of E&C few days back outside hospital. Now she is complaining of lower abdominal pain, vaginal discharge, and temperature. The BP is 90/50, pulse is 120 per minute. So, what is the diagnosis, the management, and the complication? Another scenario is that P2 had termination of pregnancy outside hospital. Now presents with hypotension, tachycardia, and temperature is 101 degree Fahrenheit. Lower abdominal pain and foul spelling is present. So, what is per vaginal examination, the diagnosis, the disease, the investigations, and the management? So, the definition of the septic abortion is that septic abortion is applied to a condition when a patient acquires infection after any type of the abortion. The clinical features are mild and severe. The mild clinical features are lower abdominal pain, mild vaginal bleeding, pyrexia, and malaise. The severe features are high temperature, foul smelling, and vaginal discharge. The investigation options for septic abortion are examination is and there is temperature, rapid pulse, small amount of blood with full discharge, rigid uterus, adnexa, tenderness, distended abdomen. On ultrasound, retained products are present, gaze shadows is present, SIDs may be present. The routine investigations are RFTs, coagulation profile, high vaginal swipe, and ultrasound. The treatment options are admit the patient and stabilize the patient. Intravenous antibiotics for 24 hours are given, that is ampicillin, metronidazole, gentamicin before E&C. Fresh blood is given, give analgesics. Record the vital signs, that is pulse, BP, temperature, and respiratory rate. Look for the signs of the pelvis, that is abdominal peritonitis. The correction of the fluid and electrolyte balance is done. Catheterize the patient for intake output record. RFTs and coagulation profile should be carried out. Blood transfusions may be required, so pint of blood should be arranged. In OT, E and C, after stabilization for pelvis abscess, laparotomy plus drainage is done. If there is uterine or gut perforation, do end-to-end anastomosis as a last resort hysterectomy. Differential diagnoses are abortion, that is threatened, inevitable, incomplete, or missed abortion, induced septic abortion, molar pregnancy, ectopic pregnancy, cervical polyp growth. The complications are hemorrhage, sepsis, coagulopathy, renal failure, complications of the treatment, then late pregnancy, and then the complications. So we have discussed the septic abortion, and we have discussed the scenario of the septic abortion, that there is a P2 who has come to OPD with history of E and C few days back outside hospital, now complaining of lower abdominal pain, vaginal discharge, and the BP is 90/50. So we have discussed the definition, then the clinical features which are both mild and severe, then the investigation options which are examination, then ultrasound and routine investigation, then the treatment options are done, then we will do the differential diagnosis and the complications. Now coming towards the incomplete abortion, we are having a scenario that there is a G2P1 with 10 weeks pregnancy, comes with pain, abdomen, and the passage of clot. So what is the diagnosis and the management? The definition of incomplete abortion is that abortion is said to be incomplete when the products of conception are partly expelled and partly retained in the uterus. The management options for incomplete abortion are investigation, examination, and ultrasound. Examination is done on speculal examination. Vagina is full of products of conception which are seen coming through cervical os. Uterus is firm, tender, and smaller than duration of the gestation. Then ultrasound is done, that is for retained products appear as an irregular hyperechoic shadow and distended uterine cavity. The treatment options are that treat it as an acute emergency, do a cohesion of the uterus, check and record vital signs, that is BP, pulse, and temperature, give hemorrhagic shock, arrangement of blood, 40 units of oxytocin, and ringer lactate. Products of conception from the vagina, cervix, and uterine cavity should be removed digitally as much as possible to avoid uterine perforation. Then the cavity is curated gently with blunt and not sharp curate. So we have discussed the incomplete abortion, the scenario, the definition, the management options, and the examination, the ultrasound, and the specific treatment for the threatened abortion. Incomplete abortion. Now coming towards the threatened abortion, we are having a scenario that there is a 30-year-old G3P2 comes to gynae OPD with 6 weeks pregnancy and complains of mild bleeding. So what are the differential diagnoses? Enumerate the relevant investigations and the management. Another scenario is that there is a 24-year-old present with 6 weeks pregnancy and spotting PV for last 2 days. So what are the differential diagnoses, the investigations, and complications? The definition of threatened abortion is that it is a clinical entity in which there is threat to abort but pregnancy can still continue. The clinical features are gestational amenorrhea, vaginal bleeding, small bright red in color, and it is spineless. So on examination, GPE, pulse, BP, temperature, CVS, and RS is present. fundal height corresponds to POG. If patients presents before 12 weeks, uterus won't be obvious. Per abdomen or auscultation, fetal heart sound is present. Per vaginal, serialized speculum examination is done. Cervical os would be closed. Size of the uterus according to POG and slightly bleeding will be present. On investigation, routine investigations are done, that is HP, RBS, urine RE, screening of the hepatitis B, C, HIV, blood group, and blood sugar. Ultrasound is done, it is confirmed diagnosis, fetal cardiac activity present plus regular gestational sac with plenty tissues present, fetal movement is present and exclude the pelvic pathology. So the treatment options are not life-threatening condition. Advise bed rest for duration of the active bleeding and 48 hours after stopping of bleeding. Multivitamins per folic acid plus Rh negative women should be given an injection of NTD to save them for isoimmunization. Okay. Emphasize the need for regular checkups during pregnancy and appropriate advice on travel, household work, and avoiding exertion and coitus. Follow-up ultrasound is done to antenatal booking and next visit after 2 weeks to confirm the gestational age plus viability. So in the end, we have discussed the threatened abortion and we have discussed the definition of the threatened abortion, then what are the clinical features, what examinations should be done, GPE per pelvic examination, per abdomen examination, per vaginal examination, and investigations are routine investigations in ultrasound, and then we have discussed the treatment options, and then what is the follow-up ultrasound. So here we have discussed all the top types of abortion, that is abortion, recurrent abortion, septic abortion, incomplete abortion, and threatened abortion. In the next section, we will discuss the ectopic pregnancy, the endometriosis, the adenomyosis, and the UV prolapse. Thanks for watching.